Very good morning to one and all. I hope you're all doing good. So today's class topic is on gingival crevicular fluid. So what is GCF? It is basically a tissue fluid that seeps through the crevicular and junctional epithelium, and it is increased normally only during the presence of inflammation or other stimuli. Basically, it's always produced, but it gets increased in certain scenario. Definitions for GCF. So what is GCF? Basically, it's a complex mixture of substances that is derived from your serum. It consists of leukocytes, structural cells of the periodontium, which get sloughed during the routine remodeling of tissues, and oral bacteria. So basically, this GCF is originating from the gingival plexus of blood vessels. So we all know that gingiva is highly vascular and it is supplied by the periodontal plexus, the periosteal vessels, and the gingival plexus. So all this vasculature are going to give rise to your GCF. And this GCF will flow through the basement membrane and cross the junction epithelium and reach the gingival sulcus. Okay, there are two theories for the production of GCF. Okay, two theories are proposed. According to another theory, they consider it to be a part of the interstitial tissue fluid, so which comes out through the sulcus because of an osmotic gradient. So early researchers have done a lot of experiments on animal models to find out the gingival crevicular fluid, its composition, and how it flows, etc. So in the earlier days, Warehog had conducted experiments on animal models using dogs and India ink, and they found that it got eliminated. The ink was totally washed out within few hours. So that's how they understood that it is continuously produced and it is in a flowing state. So it's not static. Okay, just like saliva, it clears off. So formation of GCF, as we already suggested, there are two theories that are proposed. One by Brill. According to him, it is because it is derived from the gingival plexus of blood vessels, and it is caused because of the increased permeability of the vessels. So because of the vascular permeability, there is seepage of fluids into the sulcus, resulting in the formation. The other theory by Pashley and Alfano suggests that the initial fluid just represents your interstitial fluid, and because of osmotic variation or gradient, it flows into the crevice. And in a normal subclinical state or a healthy state, this is a transudate. So we know what transudate and exudate is. So exudate is a part of any inflammatory condition, be it an abscess or any other inflammatory condition. The fluid is called as a exudate, which will have your pus cells. It's having more of proteins. Okay, so in an inflammatory state, the GCF is considered as, and it flows back into the tissues and goes into the lymphatic system. So as we see in this diagram, you can see the formation of the gingival crevicular fluid, which is either from your gingival plexus of blood vessels or from your interstitial tissue spaces. Okay, so you see the yellow mark. So from the plexus, because of capillary permeability, the fluid seeps through the walls of the vessels and it comes out through the GCF. So when there is bacterial plaque, there is an inflammation. So there is your neutrophils that are actively fighting there. Okay. So in the GCF, there are neutrophils, there are other immune cells, there are other antimicrobial peptides. So all these form the constituents of your GCF. So now the other theory stating that it is from the intercellular spaces, interstitial fluid. So again, it has to cross over through your junctional epithelium and then come into the gingival crevice. So we have to know about the GCF flow to assess how the GCF flows. It's because of its flushing action that it is able to clear off the sloughed epithelial cells, and it is used to assess the growth of subgingival microorganisms, because we know that a periodontal pocket or a gingival sulcus is a niche for all microbiota to survive because of the environment. Okay, so it is a very good ideal place to thrive for the microorganisms, because in the salivary flow will wash out the oral microorganisms continuously, and hence GCF is like a potential tool for assessing your periodontal disease activity. So most of the biomarkers which we study, we try to take GCF samples, because periodontal pocket or the sulcus is an ideal atmosphere to study the disease process as well as the therapeutic outcomes. So when you want to assess anything related to periodontal aspects, either the etiopathogenesis or related to your therapeutic outcome, a lot of research and studies are based on GCF. Okay, so because saliva is a generalized tool, because it is used for a lot of other oral diseases, and it may not give the exact correlation like when you use your GCF. So we understand that we do a lot of GCF sampling. So we'll be discussing later on the techniques which are involved in GCF sampling. Now, what are the advantages of using your GCF? So as I told you, it has all the sources of factor. It's a source for all the factors that are associated with your periodontal disease pathogenesis and activity, progression and outcome of any therapy. So we use it, and it is highly accessible. So getting access to your GCF is very easy. So we know we have to date it from your sulcus or your pocket, and it's less traumatic. Okay, so absolutely it is less traumatic to the patients, and you're able to do repeated sampling at various test intervals. So when we take studies, we do it at baseline, before therapy, after therapy, or during the therapy. So we assess a lot of markers at different intervals, so we can repeatedly do sampling. So though we understand that there are a lot of merits with GCF, yet there are a lot of disadvantages as well, because it's not a very accurate procedure. You cannot reproduce it every time. See, today I'm able to take GCF in 1/6 mesial side pocket. Tomorrow it might be difficult for me to take it there. Okay, and your chances of causing some amount of trauma to the tissues there. Okay, contamination. See, when you do an root surface debridement, after that you take, sometimes you might induce bleeding, so it can get contaminated, and loss of sample from the collection device is yet another possibility, and it involves a lot of time. Sometimes using micropipettes, it takes almost half an hour to do a sampling. So imagine doing a sample, you need to take like 50 patients, how much. So still the advantages will always outbeat the disadvantages, and still GCF is widely used. So what are the methods of collecting this GCF? So we have a lot of methods to collect GCF. So commonly, we use the intracrevicular. Intra means inside, crevicular means crevice or your sulcus. So we place something inside the sulcus to collect the GCF. So it can be using paper strips, using twisted threads or micropipettes, or doing intracrevicular washing. So the first three are the most common types. So when you intracrevicular washing, so here as it suggests washing, so it's like you're flushing that area with a salt solution. So a fixed volume of a Hank's balance salt solution is used, and it is sent inside the oral cavity. So two techniques. One is by using a acrylic stent. It washes all the gingival sulcus, and you collect it back, and you calculate the difference in volume. It's very complicated, technically demanding procedure, and usually not done in all studies. not a very common procedure because of its inaccurate quantification and fluid recovery. So it's not used, but definitely you might have to include when you write an essay or a short note on the methods of GCF sampling. So moving on to the next method, it's micropipettes. So yes, you can see you have a capillary tube sort of a micropipette which is inserted into the gingival sulcus, and volume of fluid can be accurately determined in this. So you can see how much we have collected, but it takes a lot of time. As I already told you, this procedure is really time consuming, and sometimes, you know, when you don't do it in the right way, you should have a lot of patience when you do this. Otherwise it leads to trauma to the tissues and incomplete sample is possible. So the third method is using a twisted pre-weighed thread. So that is, you weigh the thread, you place it inside the sulcus, leave it for a time period, and you remove it after it collects the fluid, and you again weigh the thread. So based on the amount of GCF is evaluated, that is collected by a paper strip, you can evaluate by either viewing or staining with a particular stain, or weighing the strip, or the use of a Periotalk is the most suggested technique. Staining, we use an anhydrine stain. The wetted papers are stained, and then you again measure it planimetrically on a photograph. Okay. Then again, this is a time consuming procedure, and you might have some minor errors in this. And fluorescent staining, you have to, you know, systemically give the patient 2 grams of fluorescent prior to the collection of GCF. So the GCF will have a component of this fluorescent, which it will emit as fluorescence, and you can deduct your GCF volume based on that. It is 100 times more sensitive than your. And then comes your electronic method. So fluid collected on a blotter employing a electronic transducer. So the wetness of the strip will affect the flow of current. So here a 1.5 mm wide strip is inserted within the sulcus of the inflamed gingiva, and it will absorb 0.1 mg of. So this was developed by Harpo Electronics. So basically it's the flow of the electronic current which is dependent on the wetness of the paper strip. So when a dry strip is placed, you get a zero reading. When a wet strip is placed, the increase in the reading is based on the amount of, or the volume of the fluid, and it can be measured. So a lot of models are there in Periotron, 600, 6000, 8000. So what is the problem? Contamination, we already discussed, it's a disadvantage. Again, your sampling time, it is time consuming. And the volume determination may not always be accurate. And again, recovery from strips is difficult. As you know, assimilation of data becomes little difficult, and it's a concern. So now we dealt with the techniques of sampling GCF. Okay. So what is the composition of GCF normally? So normally whenever we study a composition of particular component, we try to tell it as organic, inorganic. So here, you know, this is a better way of classifying. So enzymatic and non-enzymatic. So because we have a host and bacteria in this area, so it's not just the host tissues alone. So when you take enzymatic, you have host-derived enzymes and bacteria-derived enzymes. Again, non-enzymatic, you have your cellular components, you have your organic components, and your inorganic components, mostly your. Okay, so next is your cellular elements. So under non-enzymatic cellular elements, you have your bacteria. Okay, I said bacterial cells and host cells. When you come to your host cells, I told you, no, we'll keep the cells, the epithelium is very, very active in your oral cavity. It has a very high turnover. There's continuous desquamation of epithelial cells. So these epithelial cells are a component of your GCF. And then here comes your defense cells, namely your leukocytes, that is your neutrophils. They are your primary defense. They are the first line of defense for your periodontal tissues. So neutrophils play a major role in your pathogenesis of periodontitis. Again, your monocytes, macrophages at a later stage come into role. So always these cells are a component of your GCF. Moving on to your electrolytes, potassium, calcium and sodium are commonly studied. And then your other organic components, when you take organic compounds, you have your carbohydrates and proteins. So cellular elements, as we discussed, are bacteria, epithelial cells, and your defenses. So when you take your leukocytes, you can see this is a percentage distribution and a comparison with your blood smear. So when you take the GCF, you have 95 to 97% of neutrophils. When compared to your blood, it's only 60% in the blood. So they form the predominant cell. So you can just go through the other cells also. So neutrophils most predominant, followed by your B cells and your T. So what is the source of these cells? So bacteria, we know it's from your plaque. Epithelial cells, oral sulcular and your junctional epithelium. Leukocytes from the gingival plexus of blood vessels. And erythrocytes again are from the blood vessels. So we know the role of each. Bacteria, they are the etiological agents of disease. Epithelial cells, they from the high turnover of the oral mucosa. Leukocytes, they're the immune cells. And erythrocytes, because of resultant damage to the blood vessels in the capillaries, you can get. Moving on to electrolytes, you have your potassium, sodium, calcium, magnesium, and fluoride that have been studied widely. Okay, so a lot of studies have shown that there's a positive correlation between sodium and calcium concentrations and the sodium to potassium ratio with inflammation. Organic compounds are your carbohydrates, proteins, and your lipids. Glucose, hexosamine, and hexuronic acid are also two of the compounds that are usually found in your gingival fluid. They say that the glucose concentration, especially in GCF, is like 3 to 4 times greater than that of your plasma. So why is this? This is not only because of your metabolic activity in the host. It is also a result of the metabolic activity which is undergoing by the what is bacteria. So your local microbial flora also will. The total protein content of gingival fluid is much less than that of serum. Okay, so proteins, namely you have your alpha globulins, transferrin, albumin, fibrinogen, celluloplasm, antimicrobial peptides, and a lot of other proteins are present. Then comes your metabolic and bacterial products. So these include your lactic acid, urea, hydroxyproline, prostaglandins, and these are all also present in the. And now we are going to the enzymatic components. So we know that enzymatic components, you again have host derived and bacterial. So host derived, there are a big bunch of enzymes there. Okay, your MMPs, your acid phosphatases, chondroitin sulfatase, your collagenase. These are all your enzymes. And then bacterial proteinases, endopeptidases, exopeptidases. These are all your bacterial derived enzymes. So what are the functions of GCF? It washes the sulcus, carries out the shed epithelial cells. Apart from that, they say that the plasma proteins present contribute to the adhesion of these epithelium to the teeth. And then they contain your AMPs, neutrophils. So they are a part of your immune system. They form the defense of your host. And then antibodies, again, they are also part of your immune system. And they help in diagnosis of the severity of the disease, the understanding the pathogenesis and therapy. So as we already discussed, these are the reasons why GCF is considered to be very important and vital part of the diagnosis. So it's a diagnostic tool for us to assess a lot of biomarkers. So why is all this? Why are we able to see all this in disease? That's because of your permeability of the junctional epithelium and the sulcular epithelium. So because these cells have this permeability and they allow certain tissues or certain components to go out through the intercellular spaces, that's why we are able to study them. So when you see 18% of the total volume is contributed by your junctional epithelium and contributed by your sulcular epithelium. So a lot of routes have been discussed. Either it is from the connective tissue into the sulcus or from the sulcus into the connective tissue. We understand that any route is two-way. So it can go out and come in also. Or through pathological or experimentally modified gingival sulcus. Pathological means a diseased gingival sulcus or a pocket. Experimental means we induce periodontitis. No, in animal models, we induce periodontitis and study all that. So, what are the factors that influence GCF? So, there are a lot of factors that are influencing your flow of GCF. So, as we already discussed, inflammation is a reason. So we understand that periodontal pockets are a reason. Mastication, gingival massaging, toothbrushing, they're all stimulants for your GCF to flow. And then other hormones, your oral contraceptives, another reason to increase the GCF flow. Then your non-surgical periodontal therapy, surgical periodontal therapy, restorative procedures, subgingival fillings, subgingival finish line also can contribute to an increase in GCF flow. Then you have your body temperature, your circadian periodicity, that is, you see in a diurnal 24-hour fashion, there is a variation. And application of his all that have an influence on your GCF flow. So when you take circadian periodicity, which means that from a period between 6 a.m. to 10 p.m., there is a increase in the volume. See, it's a very small amount. Okay, we're not talking like something about saliva. See, saliva we know is produced continuously. So it's not like that. This is GCF, the volume is much lesser than that of saliva. And there is a decrease afterwards. But there are some so still we cannot conclusively tell, no, you come in the morning 6, you have maximum. You go to the 9, come in the night 10, you have the least. It's not something like that you can confirm and tell. And then the sex hormones, pregnancy, ovulation, contraceptives, all is GCF production. And we understand that drugs are ejected through your gingival sulcus. Tetracycline is a commonly administered periodontal medicine because it is present in GCF. So when they do studies, initially when they did studies and systemically when they gave tetracycline, they found that it was present in the GCF. So they understood that this particular role to play in periodontal disease management. And diabetic patients, they feel that there's a high patients when compared to non-diabetic counterparts. A lot of studies were done in juvenile diabetics. Moving on to therapy. So we understand that when you do a periodontal therapy, there is some trauma to tissues. There is an inflammation. It is a healthy inflammation. No, we are trying to do a flap surgery. We're trying to do a root coverage. We're just trying to, even after an extraction, we're trying to. There is an inflammation. So there is a increase in GCF fluid in that scenario. So influence of mechanical stimulation, chewing, brushing also can stimulate the oozing of GCF. So even the minor stimuli such as insertion of paper strips can induce fluid, which can cause variation in results. And then smoking, they say that it causes an immediate, transient but marked increase in your fluid flow. So we understand why we are studying GCF. What is the importance of knowing GCF? We should know the functions of GCF, the methods of collection of GCF, okay, and what are the clinical significance. So we understand that it's very important to know because it's a diagnostic tool. So when you're going to move into research, as you finish your studies, when you want to take up research, so we use saliva, GCF and serum as one of the most commonly used tool to assess, be it any biomarker. So you should know what it is, how it is done. Okay, so please go through your textbook. This can be short note or a very short note or a essay. I understand you guys are in your third year. Don't take things very light. It's just few months. We should also understand that we are going through a very rough, time where we're not able to give you direct training. So this forum should be used in the right way. So I really felt that you guys were initially very, very enthusiastic with respect to writing assignments and this Google Classroom and all. But now I feel that you guys have become little sluggish in doing it. We understand that everyone is having a lot of constraints, but we taking a lot of efforts to compensate it by doing all this. So assignment is very important. So we recommend you to use a notebook to write assignments so that it can be used later on to study. So you'll go to final year very soon. So start writing notes and start writing these assignments within a week. So I suggest that you finish these assignments within the same week at least. Okay, so when we give you a deadline or a due date, you're supposed to complete by then. So henceforth, I would like to see that you finishing your assignments on time. Okay, so thanks for your time. Take care, stay safe. So hope to see you all soon. Okay, thank you.